All right, welcome to the MVC Preoperative Work Group. I'm Chelsea Andrews. I am one of our site engagement coordinators, joined today by a couple other MVC members and many of our MVC participants, as well as some from other CQI. So thank you all for joining us. First off today, I'm just going to introduce our guest presenter. So not so much of a guest for the MVC Coordinating Center. Today's work group presentation is featured by MVC Director, Dr. Hari Nathan. Following the presentation, we will have an open discussion around implementation successes and barriers for reducing preoperative testing within your facilities. Joined with us today are some sites who have selected preoperative testing as their value metric for our pay for performance program years 24 and 25 for the MVC, as well as some sites who have selected MSQC's preoperative testing pilot program. So thank you to those who have done so, and thank you for joining us today. We look forward to hearing from you about the work going on at your facilities. Regarding Dr. Hari Nathan, Dr. Nathan is an associate professor of surgery at the University of Michigan. Following the completion of his medical education, Dr. Nathan joined the faculty of the University of Michigan in 2014. His clinical focus includes the multidisciplinary treatment of tumors of the liver, bile duct, pancreas, and stomach. Dr. Nathan's health services research portfolio focuses on variation in the cost and quality of surgical care. Specifically, he studies the impact of innovative payment models in the Medicare program on surgical care. He has been funded by the Agency for Healthcare Research and Quality and the National Institute on Aging to the impact of innovative payment models on the cost and quality of surgical care. Currently, much of his work focuses on strategies the hospital systems could use to improve the value of healthcare. Dr. Nathan was also awarded the 2018 Joan L. and Lewis H. Jacobson II Promising Investigator Award by the American College of Surgeons in recognition of his past work and anticipated future contributions. Dr. Nathan became the Director of MVC in 2019 and is a very valued part of our team today. So thank you, Hari, for joining the MVC today for the presentation. Before you begin, I'm going to go over some brief housekeeping items. Just as a reminder, the session is being recorded. We will be sharing the recording link on our MVC YouTube page to all registrants following the conclusion of today's work group. You are welcome to share that with anyone who was unable to attend today as well. At the end of the session, we have a question and answer session just for an open discussion. You are also welcome to put your questions in the chat or unmute and ask questions throughout the presentation. And then after the work group concludes and sending out the link, we'll also be sending out a link for a brief survey. If you could take just a couple minutes to complete that, it's only a few questions. It'll help us assess our current work group topics and future work group topics and make sure that we can best serve you. So thank you so much again. I'm going to transition over to Hari and give him control.
Thanks, Chelsea. So can I advance on the, do you want me to share my screen with the presentation?
If you're welcome to, or I can give you remote control, either is fine.
Oh, that's fine. I didn't know you could do that.
Okay,
sure.
Let's try that.
Well, thanks everybody for joining. And maybe I'll just say as we are beginning that, I welcome your questions, and I really welcome your questions throughout the entire presentation. And so I'll ask for my colleagues from MVC to maybe keep an eye out at the chat and also keep an eye out on the gallery view to see if somebody's got their hand raised, and just feel free to interrupt me if I'm talking too much and I need to take a pause and see what questions people have. I do not know that I have ability to, oh, did I just do that?
Yes.
Great. Okay, so we are first going to talk about a brief introduction to MVC. I think a lot of you are probably somewhat familiar, so I just want to level set and get everybody on the same page. But we'll spend the bulk of our time talking about an overview of our preoperative testing collaboration. We'll describe what we've done to date and what some opportunities are for involvement in the future. And then I hope to have a good discussion around that and to hear from many of you about what your thoughts are, maybe what you're doing, where you perceive the challenges in terms of doing this kind of work. So the purpose of the Michigan Value Collaborative is to improve the health of Michigan through sustainable, high-value healthcare. And we envision doing that by helping people access the right care at the right time, at the right cost. And if that sounds like an ambitious purpose and vision, it is. But for us, it's kind of a guidepost in order to make sure that every activity that we engage in is in some way tying back to this overall goal for the organization. We currently have 143 member hospitals and physician organizations. MVC initially started with a focus only on inpatient hospital care, but over the last few years, we have really tried to broaden that. And the biggest component of that has been engaging with POs. But we also, even in collaboration with the hospitals, are looking to expand our scope beyond just inpatient care and to really think more globally about the entire care pathway for patients. I'm going to just pause and just make sure everybody can hear me. Maybe Chelsea, just give you yeah, great. We have some service lines on our website, and these effectively represent more than 40 medical and surgical conditions where we process claims on a routine basis and provide routinely updated benchmarking data to our constituent members. And we also issue a variety of reports on a service line specific basis to kind of let people know where they are. Many of you may have seen this with respect to the preoperative testing report. And we have similar reports for a variety of other service lines that we update on a periodic basis, depending on how much movement there is in that particular field. And in all, we have about 10 years of episode-based insights on healthcare value. And so it's a very valuable resource, and we're always open to ideas as to how to best use it to provide useful insights for our members. So the data come from claims that come from Blue Cross Blue Shield, so 3.5 million claims from BCBS PPO, I should say beneficiaries rather than claims, 800,000 from BCN, 300,000 from Blue Cross MA PPO, 100,000 from BCN MA HMO. And then the other sources that we use to supplement this are 1.9 million beneficiaries from Medicare fee-for-service, and then another 1.8 million beneficiaries from Michigan Medicaid, which is the most recent addition to our portfolio of data. And so when we add all of this up, we cover approximately 84% of Michigan's insured population, which is by far the most complete data set of claims data that's available for both hospitals, POs, and researchers who are interested in understanding how we deliver healthcare in the state of Michigan. So that is a brief overview of what MVC does. And maybe I'll just pause for a second and see if there are any questions at this point, especially from those who perhaps are less familiar with what we do. Okay. Okay. So let me talk a little bit then about the, thank you, preoperative testing value campaign. The goal of this campaign is to reduce unnecessary testing before low risk for the rest of this. I want to really be clear that we're talking about routine unnecessary testing before low risk surgery. And so we're not talking about particularly complex procedures. We're not talking about testing with a specific clinical indication, but rather kind of the shotgun approach of let me just send everything before I take this patient for a relatively straightforward procedure. Is that really necessary? Is that really benefiting patients? So what do MVC data and research evidence reveal about current testing practices? Well, we have analyzed the claims data that I referred to a couple of slides ago to look at the prevalence of preoperative testing before low-risk surgical procedures. And we picked a portfolio of 3 surgical procedures to do some initial exploratory analyses with this. And we found a couple of very interesting things. One is that there is significant inter-hospital variation in well as thinking about opportunities for improvement. And so we see this as a real indicator that there's some work to be done. Somebody's saying no audio. Is that?
It's back now, but you were cutting out
I
for
got
a
a
second.
unstable internet connection message for a second. Sorry about that. So if I need to repeat anything, just let me know, but hopefully, so what's the definition of low risk surgery? Very good question. So as I said, in this particular case, we picked just 3 index procedures, and those are laparoscopic cholecystectomy, inguinal hernia repair, and mastectomy. And so those are generally considered to be fairly low risk, typically ambulatory procedures. And the evidence is quite good that for procedures like that, as I'll talk about in a minute, that there's no value in routine preoperative testing. So going back to the findings from this initial report, first, wide intra-hospital variation, and second, evidence of intra-hospital variation by surgeons. So even within institutions, we see practice variation between surgeons operating at the same place. And then finally, there's not really been a lot of movement over the years. And so there's always a concern with data like this that they may not be representing the true state of where things are in March of 2023. And I can tell you that, looking at this fairly comprehensively, it really wasn't any different in 2021 or 2019. And what that means is that we're able to aggregate enough of a sample size in order to really give you a good sense of where you stand. There was a question in the chat about any chance of including cataract surgery in ambulatory surgery centers. And, certainly everything's on the table. This is still very early. And, one of the things we certainly want to hear about from all of you is what you think would be valuable. We obviously won't be, I'm sorry, I misspoke, hernia repair. Well, oh yeah, I said mastectomy, I meant lumpectomy. I apologize about that. Hernia repair, cholecystectomy, and lumpectomy. Certainly there's a variety of other procedures we could include, and cataract is potential procedures really would kind of be those index procedures that would help you drive change in your institution. So welcome any additional thoughts as far as that goes. Let me see if I can, somebody missed what I said. I'm not sure what that was referring to, but I'm happy to repeat if anyone can let me know what was missing. So this is the initial preoperative testing report that we sent out to our members. And I don't want to belabor these because we certainly could spend the whole time going over the details of these reports, but I just want to bring out a couple of highlights here. So first, there's a patient population snapshot in order to provide details on patients. And what we want you to know there is just, who's in this cohort, right? What's their average age? Who has a lot of comorbidities? And what are those top 3 comorbidities? So the report starts with that. We then go into the preoperative testing rates for patients undergoing cholecystectomy, hernia repair, and lumpectomy. The tests that we looked at were electrocardiography, cardiac tests, blood tests, urinalysis, chest x-rays, and pulmonary function testing. So these are all fairly common tests that are used in the preoperative setting. And we looked at those with an eye towards kind of understanding what's the utilization of any of those tests, what's the utilization of specific ones, and that's effectively what you're seeing here. The pre-op report really gives insights, as do many of our reports, into not only what your rates are, but where your peers are. And that's really important, right? Because if I have a 50% rate of preoperative testing for low-risk procedures at my hospital, well, is that good or is that bad? I mean, the right number is clearly not 98%, but the right number probably also isn't 0, because we acknowledge that in claims data, there's going to be some room for kind of nuance, and we may not know all the clinical details. And so 0 may not be the right number either. And so the benchmarking is really important, because if you're at 60% and everybody else is at 20%, then there's probably an issue there. And that's kind of the approach that we take in terms of identifying opportunities to improve. I saw there was no audio on the cataract. Sorry about that. So what I was saying about cataract is, that's certainly something we could look at. But at some level, we can't be exhaustive with the procedures that we include. But if cataract is one that, there's agreement that it would be very helpful, certainly that's something we can look at. And since you brought up cataract, thank you for the segue. That's actually where a lot of this work started in the academic literature. So looking at fee-for-service Medicare beneficiaries undergoing cataract surgery, which, as you all know, is a very low-risk procedure. It's outpatient. Often people have one eye done and come back a couple of days later, a week later, and have the other eye done. And so really not much indication, except in very specific circumstances, to do electrocardiography or lab work and that sort of thing. And these findings have been replicated in a variety of different procedures. So looking at non-cardiac elective surgery broadly, looking at other urologic ambulatory procedures, minimal risk patients undergoing elective surgery. There's many, many papers looking at this and very robust evidence to show that for low-risk surgery, routine testing doesn't improve patient outcomes, costs the US about $85 million a year. And you might say, in the grand scheme of things, what we spend on healthcare, frankly, although it sounds ridiculous to say this out loud, $85 million isn't a lot of money, right? But that only so POs will also be getting this information. Great point. So, not only really is it objectively a lot of money, there's a lot of things we could do with $85 million, but the other issue here is that these tests may then lead to more tests, and they may lead to invasive procedures, and they may lead to real patient harm that's not encapsulated in that $85 million figure. So it's really important to think about all of the potential downstream consequences when we do these things and when they're not indicated. Multiple medical societies recommend against this practice. There really is broad consensus on this issue, and yet the practice persists. And there's common reasons that we hear about why do we persist in ordering blood work on a 35-year-old who's coming in to get a groin hernia repaired, right? It's better to be safe than sorry. What harm could it do? I don't want my case to get canceled. I'm a surgeon. I've been there, and I totally understand. Nobody wants to hear the morning of that somebody feels that we should have gotten X, Y, or Z test, and because we didn't do it, the case is going to get canceled. I don't see any benefits to this initiative. But we talked about that, right? Not only is there an issue with cost, but there's an issue with harm. And so the perception that there's no harm in ordering these tests really is incorrect because, again, this has been studied and there is a downstream cascade of testing that can happen, and it can result in real patient harm. Everybody orders these tests. Again, this is why the benchmarking is so important, right? Because I just showed you, everybody doesn't. Right? There are hospitals that have testing rates of 20%. So it's really important to understand that. And I think as you all are talking to providers at your institutions who may be the ones who are actually placing the orders for these tests, that's a really important thing, right? Because I think we do live in a very, unfortunately, litigious environment. And there is some risk aversion here. And I think that feeling that it's better to be safe than sorry can cloud our decision making. And I think making the point that this is, you're on solid ground here. This is well accepted practice to avoid routine testing in this scenario. And there are hospitals and surgeons in the state who are doing exactly that. And so that's a really important piece of information, I think, to share with providers. Barriers to de-implementation, getting people to stop doing this. Number one, gathering good data and clinical feedback and letting people know what your rate really is. And is it the same across all procedures? Is it the same across all surgeons, et cetera? Provider habits. We're creatures of habit and we have routines, and often we have pre-made order sets, and these things kind of happen at the click of a button. And so kind of unlearning that and deconstructing that infrastructure can be a challenge. And then finally, conflicting EMR processes. And so, the implementation or de-implementation in this case of this may be different at every institution because of the way that their particular workflow works. So now that I've talked a little bit about where these, what the data tell us, both the MVC data on practice patterns across the state and research in terms of the potential benefit or harm from doing these things, let's talk a little bit about opportunities to move the needle in the state and really highlighting some ready-to-use resources that I think will be helpful to all of you all. So first, in partnership with MSQC, the Michigan Surgical Quality Collaborative, and Improve, which is an organization here at Michigan that does a lot of work with de-implementation work and implementation of good practices. We're developing resources that we will make widely available to our members to try to implement initiatives to reduce routine preoperative testing. And so we have a website called Wave the Workup, and that's focused on providing resources to sites who are trying to reduce low-value preoperative testing. Valerie Gavrila, who's a project manager with Improve, led the development of that website. And I think she's here and can answer any additional questions if there's specific questions about the website. Here's an example of a flyer that's available on the website where, kind of goes through a lot of the issues that we've talked about here in the last few minutes. So this idea of a cascade effect, the idea of delaying the operation that the patient's there for because of false alarms that can result, or tests that are barely abnormal, but nevertheless prompt a very extensive workup, and then costly waste. So all of these things are reasons. Here's a nice flyer that you can download, you can customize with the logo of your hospital, and you can use at your own institution, along with a QR code that allows people to get additional information. Here's a decision aid, which again can be customized, and you can insert your hospital logo here. And this, particular decision aid is specifically talking about the 3 procedures that we analyzed in our initial review. But of course, it applies more broadly to a variety of low-risk operations, and it goes through a little flow chart where you think about the patient's risk, do they need preoperative testing or not? And this can be an aid. So there's a comment in the chat that according to some anesthesiologists, a diagnosis of cancer puts patients into an ASA classification of 3. I'm not an anesthesiologist, but I can tell you that's just not accurate. That is not enough to get you an ASA classification of 3. But I think that, again, this is where provider education is really important. And the important thing to convey, I think, well, there's 2 things that I would say. Number one, at the end of the day, we are not trying to substitute for the judgment of the clinician at the bedside. We fully recognize that all this decision-making needs to be individualized, and there will be certain circumstances in which we will choose to send these tests, even for a low-risk procedure, and that's okay. And that's why I say 0 is probably not the right number. On the other hand, we kind of hear a common refrain, right? And when I say hear it, I mean, I'm guilty of it too, right? This idea that my patients are sicker, my patients are special. All patients are special, but your patients are not sicker, I guarantee you. When we actually look at the data, what we find is that even in healthy patients, these tests are overused. But importantly, the guidelines around this, the data around this, are not restricted to only healthy patients. So even patients who have significant comorbidities have been shown not to benefit from routine preoperative testing. And I'm not talking about the patient who comes in and says, you know what, I've been having this intermittent fluttering. I don't have a diagnosis. I'm about to get a lap chole. Absolutely, that patient should get an EKG, right? That's not necessarily what we're talking about. But the patient who has no such complaints, even maybe with a remote history of some kind of cardiac disease, should not be getting an EKG. And that is very widely agreed upon in the literature and by specialty societies. So if you look at the ASA classification, it's on this slide. I think you can see that, class 3, having cancer doesn't put you in class 3. That's not typically how that classification is to be used. So here's a table that, again, this is downloadable, customizable, but can give you some guidance and allow you to disseminate this amongst your teams in terms of, well, when is it appropriate, right? And here's some examples. It's not an exhaustive list, but there may be certain situations in which you do want to order some of these tests. And what I would encourage you all to think about, and as you're discussing this with your teams, to include as part of the discussion is, just because I need to order one of these things doesn't mean I have to order all of these things. And I think sometimes we fall victim to this approach of just fire the shotgun and get everything. Oh, as long as you're going to stick them and get blood, you might as well send everything, right? I've said it. It's not right, but I think many of us are guilty of this. And I think we can be a little bit more nuanced about it. So this is a useful figure, I think, in order to kind of think about, do I really need all of these things in all of these patients, or should I be a little bit more focused? And that's really all we're saying, is rather than ordering these things as a knee jerk, rather than do this as kind of a one size fits all, to really kind of think about it before ordering and to make sure that it's really necessary or indicated in that particular patient's case. Just pause for a second. I know there's been some chatter in the chat, which is great. I'm trying to kind of amplify things as necessary, but there's a really nice response there from Tony that says it better than I did, frankly. In June of 2022, MVC also launched our first pre-op testing awareness week in order to raise awareness of the prevalence of unnecessary preoperative testing and opportunities to reduce it. And so our goals were really to provide the information to allow people to understand what the scope of the problem is, to show them how variable it is between hospitals and providers. Because again, I think whenever we see unwanted variation, it highlights either underutilization or overutilization, depending on the particular case. And connect members with resources, such as the ones I've shown you on the previous few slides. And so there's a video here that is a great example of one of those resources. So let's see if we can click that. Do we have audio?
We can't hear anything.
Yeah. Well, maybe we'll skip the video. Sorry about that, but there is audio if you go on the website, so feel free to do that. And I lost the.
Sorry, I was gonna try to get the audio to go back on.
Oh, okay. Well, while Chelsea's working on that, the next slide really is just talking about the fact that, as I started with the idea that really what we're interested here is in your perceptions of this problem, in your ideas about how we could try to actually change practice around this. Are there particular challenges that you've already encountered if you've kind of dipped your toe in the water of trying to do this work? Or if you're an organization that's looking at the possibility, what do you perceive as some of the barriers, and how can we help? Because ultimately, we're really interested in partnering with all of you to try to provide the tools and to try to make this as painless as possible as you try to reduce preoperative testing. So we'll keep working on the video, but really we're at a point now where we can have some group discussion. And I think if we can get the audio working, we'll interrupt the discussion and watch it. But there's a few things that I'd like for you all to think about. And if you wouldn't mind chiming in, we'd love to hear your thoughts. First, in your facility, who determines what tests get ordered? Because obviously that's very important in terms of then figuring out how to get them not to do that in certain cases. Are there already some tools in development at your institution in order to try to address this problem? What barriers have you faced for those of you who have started to explore this? And where do you think the challenges will be in terms of reducing preoperative testing? We highlighted some of them from our perspective, the idea, for example, that better safe than sorry, or the idea that it doesn't really hurt anything. But I'm sure we've missed some things, so we'd be curious to hear from you all about that. And then finally, what can MVC, MSQC, and Improve do to support you all? And what can we do to be helpful in addition to providing data and starting to develop some toolkits? We're open to any and all ideas. And so I see one person chimed in that it's surgeon driven. Certainly at many institutions, that's the case. I don't know how many of you all have a preoperative clinic. We have one here where we have advanced practice providers who are largely the ones who are driving the orders. And here's another institution where it's anesthesiologist driven. So already you can see, and here we go with an APP in the PAT department. So I think already just with 4 comments here, you get the sense, as the slides, as the graph showed previously, that there's variation in the rates and there's variations in the workflow. And I'm sure those two have something to do with one another. And I think what will be key here as we're working with you all to do this is to really understand your local environment and who's making the decisions. Because if at your institution, anesthesia is deciding, if we are harping on the surgeons to stop ordering tests, obviously that's not going to have the desired effect. So we really do want to understand the local environment, and it's going to be different for each of you. We fully appreciate that. So if anybody would like to either add more thoughts in the chat, or feel free to unmute and share your thoughts out loud, we'd love to open it up now for some discussion, and also happy to answer any additional questions that come up along the way.
Hi, this is Monica from St. John's.
Hi.
Hi, so our biggest thing, I feel like we already looking at our pre-surgical protocol with anesthesia and the surgeons. We're similar to what you have already, but when we're sending patients for medical clearance, that's kind of where we run into issues of things maybe being ordered that might not necessarily be necessary. So that's why I was wondering, will the PCPs be getting this information too? Because we're putting it at their discretion because they know the patient best.
Yeah, it's a very good point. I think that, if we had embarked on this work 5 years ago, we would have fallen on our face, because at that time we were only working with hospitals. And I think you highlight that it's going to be a very multidisciplinary effort, and we have to involve the PCPs and the medical specialists, not just the surgeons, not just the hospital staff. I think there's a few issues there. One is, and I say this as a surgeon, what are we asking them for when we send the patient for pre-op quote clearance? Because usually this has to do with cardiac risk stratification. And I think, clarifying what it is that we're asking the PCP to opine on avoids putting them in a situation where they're having to order a bunch of stuff because they feel like they're going to be on the hook for anything that potentially got, quote, missed. I think the second piece of this, however, is to disseminate this information to the PCPs as well. And I mean, not just the data on testing, but also the research on testing, because from a PCP's perspective, they may not necessarily know offhand what constitutes a low-risk procedure or not. And they may not be aware of all of the data and the society recommendations against preoperative testing for particular situations with low-risk surgery without particular clinical indications. And so I think disseminating the information is a big deal. And absolutely, this idea of a just-in-case kind of thing is going to be one of the major barriers that Audra, it looks like, highlighted here in the chat. Hopefully that answers your question about PCPs.
And I have another one kind
Please.
of tag on to that. So when we're looking at our reports, that's the claims made at our hospital, correct?
Right.
So when we're abstracting currently for this pilot program, it's anything that we see in the chart, regardless of where it was ordered, who ordered it. So how was that going to be looked at? Because it might be skewed, we're looking like we're doing maybe more on our end because we're just abstracting, this is the date, this is the test, but it doesn't reflect where it was necessarily done.
Right. So great point. So yes, as we're collecting data on testing, obviously the most important thing from the patient perspective is, did they get the test or not, right? Because at that point, it's somewhat agnostic to who ordered it. Now, of course, for us to then target the QI effort, we do need to know who ordered it. And we've been able to get a little bit of insight on this from the claims data, but the claims data, frankly, aren't great for this. And so I think this is where it'll be really important for people at each of the institutions to really understand what their workflow is. So the idea, for example, that Cameron brought up of sending the patient to the PCP for pre-op clearance is a really important thing. Now, that may not be universal, right? But at certain institutions, if that is a predominant practice, then clearly that's something we need to understand in order to intervene at that level. Whereas at other institutions, if there's a preoperative testing clinic, then that's going to be the place that we're probably going to get the most bang for buck. So I think we are really going to rely on you all to tell us about what's going on in your institution. And I think for purposes of data collection, we certainly do want to count any test that gets done, but then we are going to also have to do a little bit of a deeper dive to understand where those orders are coming from so that we can get upstream of the test and try to intervene. Does that answer your question?
Yes, thank you.
Okay, great. Thanks for the questions. Who else?
We did receive a question. Is this something you'd be willing to share with the POs at a quality committee or any other group outside of the work group?
Was that a question for me?
Yes, yes.
Oh, sorry. So
Sorry.
would we be willing to share this?
Yeah, with like any PO quality committees, I know we'll be sharing the link, but are there any other resources or guidelines that you could share with members outside of the recording today?
I think the question was asking whether Hari could do a presentation to someone's PO quality committee.
Hand from Lisa Rosario.
Oh, sorry, Hari, we lost you for a second.
Oh, okay. Well, I think there was a raised hand from Lisa.
It was, thank you. I was going to type it out in one. I just want clarification. You guys said at MVC, you're collecting inguinal hernias only
So,
for the low risk?
right. So we have 40 plus service lines of data where there's data that's updated on a regular basis on a variety of medical and surgical procedures. This particular project, we started with those 3 procedures. So inguinal hernia only. Really just as a demonstration, right? And so we tried to pick procedures that are almost always going to be fairly low risk. And so, one reason we didn't look, for example, and I assume your question is getting at the fact that we did not look at ventral hernias or incisional hernias and that sort of thing.
Really, my question is, I'm with MSQC, and we are collecting all open inguinal, femoral, umbilical, and all laparoscopic hernia surgeries.
Yeah, I think all of those would generally be considered low risk. And so, in the claims data, because we don't necessarily have the same access to the clinical details that you do when you're abstracting a chart, we tried to pick procedure codes that would be pretty clean and would be pretty homogeneous with respect to the risk profile of the operations. The problem, if we were to include codes for more complex procedures, even if they're not ventral hernias, even if they are femoral or something like that, is, there's a risk of having a more heterogeneous cohort and introducing more opportunities for variation between facilities and between surgeons, which then make it hard to benchmark people against each other. So this is kind of, as one of the things we're always kind of dealing with is trying to pick a group that's homogeneous enough that we're making fair comparisons. And so that was the reason. It's not to imply that only inguinal hernias fall under this. That's not it. Just as you said, I think, on the clinical chart abstraction side, I think we can be a little bit more inclusive.
Thank you.
So I would say that in terms of, a motion to improve primary care, that's probably outside the scope of this project. But I think with respect to improving the awareness among primary care providers of this issue, that's certainly going to be part of the initiative. Any other questions? I think Jenny's comment tags on to Lisa's a little bit, and maybe that's a discussion to have in a different forum in terms of how we're coordinating with MSQC on this. But I think the point here is that although we're starting with a few procedures for ease of data collection and for ease of implementation, if you want to be more ambitious and roll this out kind of across low risk procedures at your institution, we'd be happy to support you in that as well. We felt that by focusing on a few index procedures for instances where, for example, in a particular institution, if it's being driven by a few surgeons, by focusing on a few procedures, again, we kind of keep the problem as contained and as straightforward as we possibly can, at least as an initial step. But clearly, as this gains steam, we'll want to expand beyond that. And certainly what we've seen in other such QI projects is that there typically are some spillover effects, right? So if we can get the surgeon who mostly does lumpectomies to stop ordering routine preoperative tests, then when that surgeon is doing the occasional other operation, whether that's a hernia repair or something else, hopefully she or he will be equally judicious in terms of deciding whether there really is a need for testing or not. think a lot of this is just retraining our brains as clinicians to not do the same thing that we've always done. MVC team, what have I left out? Feel free to chime in and make any points that I didn't.
No, I think this is great. Thank you, Hari. I think you covered everything in excellent detail. And apologies to those who heard the audio issues earlier. Not sure what was going on, but I think we've resolved it. So
Can you hear me okay?
Yeah.
Okay. I would just maybe add if, you know, as sites are working on this, if there are particular resources, you know, or materials that we haven't already presented to you that would be helpful, you know, our team is still actively working to develop those tools. So if you feel free to share that here or over email offline, I can pop my email into the chat in case you have suggestions for things that would be useful to your teams. Even if it's just talking points, you know, for working with physicians.
we have gotten a lot of positive feedback already about today's presentation. So thank you, Ari. And to add to that, you know, in regards to things that we can provide you guys to support your efforts, this recording and the presentation slides will be available for you to distribute to any groups that you think would be valuable in reviewing them, as well as other members at your organizations.
You're muted, Hari.
Thank you. Pop-up tools is the question that Cameron asked about. Do you mean pop-ups in the EHR? Yeah, so certainly that would be something that you could choose to integrate. I think those kinds of alerts are a double-edged sword because there's, you know, there's certainly a degree of pop-up fatigue that can happen where people just start clicking through things because they just want to get to the next step. So I think, you know, we'd really have to think about whether that's going to be the most effective intervention or not. You know, my personal feeling is that this shouldn't be about making people's lives difficult if they want to order a test and hoping that, you know, they'll stop ordering them if we just put enough barriers in the way, right? I think rather than that, I'd rather focus on kind of the education piece and, you know, the reassurance that this is okay and has broad support and other people do it and it's fine. And you're not going to be the lone person out there not getting tests before these procedures. And God forbid if something bad should happen, that's going to come back to bite you. I think that's a very common perception. And I think that really battling that perception is going to be a huge thing. There are definitely challenges with respect to, you know, EHRs that either are being implemented now, as Chelsea pointed out, or there are some systems where they're not using the same EHR across the system. And all of these are definite issues that we may have to deal with. Lisa asked a question that I hope will be the first of many of those types of questions, because we do very much encourage you all to share solutions with one another. And so thanks, Lisa, for bringing that up. And certainly if anybody has ideas or things that they are already doing and would like to share, this is a great time for that.
Jenny, you've got your hand up. I'd welcome you to unmute if you're available to.
Can you hear me now? Very good.
Yep.
Yes, we can.
Dr. Nathan, would you go back to the slide with the decision tree, please?
Chelsea, do you mind going back to that?
Our facility, we're working on a decision tree, and ours happens to start with, is the procedure one of the 3 indicated procedures? And then it goes to patient's ASA class. And I see that's not the same as this recommendation. So maybe you can prevent us from, what's the rationale for starting with, well, actually you did start with the procedure and then ASA.
Yeah, I think we're actually doing the same thing. But, you know, your point's well taken. There's more than one way to skin this cat. I mean, you know, in presenting this flow sheet, by no means are we saying this is the way to do it. And again, I think as long as we're staying true to the overall principles that routine testing, meaning, sending these things without having a very specific clinical indication or concern is what we're trying to get at. And we could rearrange this flow sheet and it would be just as accurate and just as valid. And, that's the kind of customization that we want to help you all with. And we can kind of help make sure it's consistent with the spirit, if it would be more effective in your particular institution to do it in a slightly different way.
Very good, thank you.
So MVC data are typically risk adjusted when we're looking at clinical outcomes. The reason we're not risk adjusting in this particular situation is we actually really want to understand what the role is that the comorbidities are playing in the decision making. So we don't just want to kind of standardize everybody's rate based on kind of a theoretical patient population with a certain risk profile. Rather, we think it's important to actually show you what your real rate is in your institution, because I think that's most amenable to intervention, right? If I tell you your risk adjusted rate is 40%, I don't really know what that means. And I do this like every day, right? I think if I tell you your real rate is 40%, then that's something you can kind of wrap your head around. And so I can tell you that when we do risk adjust data like this, there's still the same variation. There's still the same, so it's not going to make any of this go away. We just think that the data are more actionable in this particular circumstance if we actually don't risk adjust away some of those things that may be actually driving the testing, if that makes sense. And as Jenna pointed out, the cost measures are price standardized. So as is true with all the MVC data, when we talk about dollars of healthcare spending, those are standardized dollars, agnostic to the payer, agnostic to the patient's specific insurance plan, deductibles, all that kind of stuff. And that's just to facilitate apples to apples comparisons, regardless of who we're talking about, whether it's a Blue Cross beneficiary or a Medicare beneficiary. We assign a dollar amount to an EKG, for example, or a CBC sent to the lab. And we apply that same dollar amount regardless of where you actually had the test done, just so that we're removing that source of variability, which for our purposes isn't particularly interesting. We're not so interested in what Blue Cross pays for a test versus what Medicare pays for a test. Rather, we just want to give you a sense of what the impact is in terms of the dollar amount. And that's where those numbers come from.
Hi, Dr. Nathan, this is Pam Rocky from MSQC.
Hi.
And I just wanted to add on to that comment about risk adjustment a little bit. Not that we're going to risk adjust our QI measure either, but I did want to let our sites know that when they get their reports from us, they'll get a numerator of every case that had at least one preoperative test within 30 days. And then we'll take that numerator number and we'll stratify it to show you what ASA classes are represented in that numerator cohort. So it should give you a better perspective of whether or not the majority of the cases that you are doing testing on are coming from, say, ASA class 1, or if they're mostly coming from ASA class 3. It can help give you just a better way to know where you need to hone your QI efforts.
Yeah, that's great, Pam. Thank you. I think you explained it better than I did. So thanks for chiming in. Well, I hope that this is just the beginning of a conversation, and we would really love to work with you all together, and also to collaborate with you individually in order to see how we can best support you as you do this. And I think one of the things that we really aspire to do in MVC, and I know MSQC also tries to do this, is to really create a culture of collaborative learning where institutions and providers are sharing solutions as well as challenges with one another. And to whatever degree we can help, please do contact us. I see Irene just chimed in, and yes, this is really only meant to be a start. And if you need help, for example, identifying peer institutions who treat similar groups of patients and do similar volume of surgery, and you want us to plug you in with somebody who kind of looks like that, many of you already know who those institutions are, but certainly if we can be helpful in identifying them, and especially because we may have some knowledge of who's already doing some things in this space, and we're happy to help make those connections if that's at all helpful to you. And I encourage everybody to go check out the website, and feel free to use those materials and let us know again how we can help customize those so that they're most useful in your particular setting and institution. So MVC team, how would you like to wrap up here? Chelsea, is there anything else that we need to talk about in terms of housekeeping?
Yeah, I can go to the closing slides and we can close it out. And we do have the video available in the presentation. We'll make sure that's linked so you guys have access to that. So thank you all again. Thank you, Dr. Nathan, for your wonderful presentation. It's very informative. We're happy that you were able to share this with everyone, and we hope that you who were able to attend can share this with those who weren't, as well as those, quality committees and other quality groups that you think this would be beneficial for. Coming up for our other MVC work groups, we have a diabetes work group on March 21st. We will be having guest presenter Ann Andrews, who is a senior program manager at the National Kidney Foundation of Michigan. We have a MVC Lunch and Learn, which is the first of its series on March 29th. Our first Lunch and Learn will be all about MVC, and a great opportunity for you to ask questions and learn more about what we do at the coordinating center. That will be from 12 to 1. And then our next work group is on April 5th. It will be a health and action work group, and the topic will be announced soon. With that, that closes up our preoperative work group for today. Thank you all again for attending and for your patience as we get things arranged. If you have any questions or if you'd like to connect with Dr. Nathan, you're welcome to email us at michiganvalleycollaborative@med.umich.edu. And we will be sending out all of the information at the end, and I hope you guys have a great rest of your day. Thank you.